Right. Today I'll be talking about this topic, permissive underfeeding in critically ill patients, way to go. So this was the debate I had in Vizag South Zone Conference on 18th August 2019. So my opponent was Dr. Jakina Boina. So I think we'll just try to understand what is the science of underfeeding. So multiple studies, animal studies have shown that underfeeding increases the lifespan and it has a lot of beneficial effects. It promotes the cell survival, it promotes longevity biomarkers, and it increases or promotes cytokine profile, favorable cytokine profile. And other positive effects of underfeeding has been found to be on metabolic functions of the body, hormonal functions of the body, and the mitochondrial functions. And what has been found is underfeeding with a normal protein intake has a favorable effect on the mitochondrial function, but not necessarily this is seen with the carbohydrate intake. And increased calorie intake in the presence of stress has shown to have variable effects on glycemia. So, if you give increased calories, they may have a hyperglycemic response in the presence of stress or hypoglycemic response in the presence of stress. And I think most clearly we need to understand what is the definition of underfeeding. So, definition of underfeeding is where we provide only 40 to 70% of the estimated calorie requirement. So, my friends, you know that we do not eat to our 100% ability to take food, or we don't eat until we are full to the stomach. So, we take only until our feeding is sort of satisfied. So, 40 to 70% of estimated calorie requirements we call it as underfeeding. So we don't have to always achieve 100%. And the key element of underfeeding is we preserve protein intake. So we may cut down on the calorie intake by cutting down carbohydrates, which is or even as a normal sort of approach to our feeding, we do subscribe to that we don't want too much carbohydrates, and we may limit the fat, but we maintain the protein intake, and we do restrict non-protein calories, which is carbohydrate and fat. So when you look at the studies on underfeeding, there are around 9 to 10 studies. So these are some of the studies. The earliest one came by Dickerson et al. In 2002, done as a single center randomized controlled trial in critically ill obese patients where enteral nutrition was given more than 7 days, 40 patients, and calorie intake was less than 20 kilocalories per kg per day, and protein, as you see, they maintain normal protein. Arabi et al. Was a 2011 study, single center RCT in patients admitted in ICU for more than 2 days who were mechanically ventilated. Much larger number of patients, 240 patients, where as you see they stuck to the definition. So I've only taken studies which confined to the definition where 40 to 70% of calories was provided by maintaining normal protein intake. Broshwick et al. Single center randomized controlled trial included acute lung injury patients, 78 patients, where again it falls in the definition between 40 to 70% calories and maintaining normal protein intake. Charles et al. Was a 2014 study in surgical ICU for more than 2 days, 83 patients, where 50% calories and they maintain normal protein intake of 1.1 gram per kg per day. And this is a landmark study, Arabi et al., which is a permit study, which is the largest study, multicentric randomized controlled trial done in patients who are admitted in ICU for more than 3 days, mechanically ventilated, 894 patients. And again, they stuck to the definition of 40 to 60% of calorie goal and maintained protein intake. Rugel et al. Was the most recent 2016 study, single center randomized controlled trial, where they gave enteral nutrition through nasogastric tube for more than 96 hours, 120 patients, stuck to the definition with normal protein intake. So let's talk about this first Arabi et al. Study, which came in 2011 in JPEN, Journal of Parental and Enteral Nutrition, 2010. This was a combined study between Saudi Arabia and Canadian group. So where they compared permissive underfeeding, which is 40 to 70% of calories with normal protein intake, and compared to the target feeding. When we say target feeding, you maintain much higher calorie intake. So they had 120 patients in permissive underfeeding group and 120 in the target feeding group. So when you look at 28-day mortality, there was no difference between permissive underfeeding and target feeding. And when you look at 180-day mortality, as you see, mortality seemingly appeared little less, although not statistically significant. But when they looked at ICU mortality, no difference between permissive underfeeding and target feeding. But when you looked at hospital mortality, was significantly less in permissive underfeeding group. So this was a first study probably which highlighted probable favorable benefit of permissive underfeeding may be beneficial in ICU. Then Arabi et al. In 2016 conducted a much larger study called PERMIT study, which came in American Journal of Respiratory and Critical Care in 2017. So a randomized controlled trial done in 7 hospitals, which was spread between Saudi Arabia and Canada. It was done between November 2009 and September 2014. The inclusion criteria was patients who were fed within 48 hours were taken, 18 to 80 years, and they had to stay for ICU for more than 72 hours. Exclusion criteria was someone who was on TPN or who had a high vasopressor need of more than zero point 0.4 micrograms per kg per minute, or who's had post cardiorespiratory arrest who would not survive, or someone who were designated as end of life or where expected survival for 6 months was less than 50%, they excluded. So they had two groups, interventions versus control. Intervention group was an underfeeding where they stuck to the definition 40 to 60% of the calorie requirement. The target group had more than 70% calorie requirement. And when they looked at the absolute calorie intake, the median calorie intake in the underfeeding was 835 plus or minus 297, which approximated to 46 plus or minus 14% of the calorie intake. And in the control group, the absolute calories they that was delivered, the median was 1299 plus or minus 467, which constituted around more than 70% of the calorie intake. And as you see in the both groups, they maintained protein intake of 1.2 to 1.5 grams per kg per day. So they maintained normal protein intake between the two groups. So they had 894 patients, 448 in the permissive underfeeding, 446 in the target feeding. As you see, there was absolutely no difference in any of the markers. 90-day mortality, death in ICU, 28-day mortality, death in hospital, 180, ICU length, hospital. There's absolutely no difference between any of the variables between permissive underfeeding and standard underfeeding. But the incidence of renal replacement therapy, which was a coincidental finding, was less in patients who were underfed when compared to standard. So this is just an observation. There was no sort of a logical reasoning that one could give for this, but this was a finding they saw in this particular study. Then coming to this Rugel study, which came in 2013 in Indian Journal of Critical Care Medicine, this was a Colombian study where they compared underfeeding with increased protein versus isocaloric. So basically, you had a target feeding compared to the underfeeding. In underfeeding group, they gave more protein, and in target feeding, they gave 20% of the calories by protein was given. So what it all entitled to was hypocaloric, high protein. They got 15 kilocalories per kg per day, which fits into the definition of underfeeding. And they got protein of 1.7 grams per kg per day. So the target feeding got 25 kilocalories per kg per day. It was a double-blind randomized controlled trial. Follow-up was done for 4 days. Primary outcome was to look at the change in SOFA scores at 48 hours. Secondary outcome was to look at the ICU length of stay, duration of mechanical ventilation, and the hyperglycemic events and the insulin requirements. So they had 80 patients, 40 in underfeeding, 40 in target feeding. As you see, the protein that was given in underfeeding was 1.4 grams, which was much higher protein. In target feeding, they gave less. That was statistically significant. And when you look at the change in SOFA, change in SOFA typically mentioning that your organ dysfunction was getting better was much higher in underfeeding group as compared to the target feeding. That was statistically significant. And what they also found in the study was the number of hyperglycemic events was significantly less in underfeeding group as compared to the target feeding. That was statistically significant. So the conclusions the author made was in hypocaloric high protein, I think it helped in reducing the SOFA scores and it helped in reducing the hyperglycemia events. So totally when you collectively look, there are, as I said, around 9 to 10 studies on underfeeding. 8 studies showed improved outcomes. There's only one study by Petros et al. Which came from the German group which showed underfeeding led to worse outcome. So when they did subgroup analysis of all these studies, and when you do a subgroup analysis and divide them into tertiles or quartiles, so what they found in all these 4 studies, Arabi et al., Krishnan et al., Ash et al., Crozara et al. From Belgian group, all these 4 studies showed that the patients with least calories did well and the patients who got the most calories, they did not do well. So their mortality was high. In fact, in Arabi et al. Subgroup, when they divided into tertiles, they found that the patient group which got the highest number of calories had double the mortality. Mortality almost doubled, and that was statistically significant. And these results were typical. So when you divide them between 3 to 4 groups as to highest calories and lowest calories did well as compared to the highest calories. That's what these 4 studies showed. So this was another study, Charles et al., which came in American Journal of Clinical Nutrition in 2014. Again, they compared underfeeding versus target feeding with equal protein, and they found no difference in outcome. So this is the previous study which I showed, where they looked at the change in SOFA by the Rugel et al. So now we have looked at the 9 studies where they show that underfeeding is non-inferior to target feeding. In the permit study, as you saw, there was reduced need for renal replacement therapy, and the first Arabic trial in fact showed that it may reduce mortality. But let's look into the meta-analysis. So this meta-analysis came by combined US and Chinese group, where they took all these 9 to 10 studies, and as you see, with regards to hospital mortality, the diamond tends to move towards favoring underfeeding, although that may not be statistically significant. And they subdivided into the groups with Apache more than 20 to see if underfeeding helped there. Even in patients where Apache was more than 20, you see the diamond tends to move towards the underfeeding. Even in patients who are less sick, I think less than 20, diamond tends to move towards left, although there's one which is sitting in the center. So the more sicker the patient, I think underfeeding seems to have a little more beneficial effect, although I have to confess none of these were statistically significant. Then again, they did a subgroup between patients who had a low BMI versus normal BMI versus high BMI. As you see, in patients with a high BMI, the diamond tends to move towards left, or BMI less than 32 it tends to move. But in someone who is malnourished, where BMI may be less, I think we all understand in someone who is malnourished, you wouldn't want to do underfeeding because diamond sort of tends to incline little towards the left. So what summarily all these slides tell you is there is some tendency to move towards underfeeding in all sick patients or in patients who may have a normal BMI. But in we agree that in someone who's malnourished, maybe these are the patients who should be avoided to getting underfeeding, or who should not get underfed. And what about the infection risk? Again, you see sort of diamond tends to move towards the left, although I have to confess they're not statistically significant. So this was my initial argument to say that underfeeding maybe definitely is not inferior to target feeding, and maybe there are 2 to 3 studies which have shown that underfeeding may be favorable. And more so when you look at those 4 studies, Prosara, Krishnan et al., Arabi, Charles et al., where they have shown that if you divide them into tertiles or quartiles, the people who were most fed did not do. So my confession would be we should not be really targeting the feeds up to 100% because they may not do well. So my opponent obviously gave his deliberation, which I would say, there was not too much of a strong arguments in the favor of overfeeding. So my rebuttal, I put up this latest study. I think my rebuttal comes from this biggest study ever, which came from the target study, because my opponents spoke about 2 observational studies which sort of favored target feeding. But we cannot compare observational studies with randomized controlled trials because it's not like comparing apples and apples. So we need to talk about randomized controlled trials as a good evidence, and that comes from this largest trial from Marian Chapman, who was my teacher in Royal Adelaide Hospital in 2018 target study. As you see, they had the largest number of mechanically ventilated sick patients, 3,957 mechanically ventilated patients who were randomized between energy dense and routine. So here you have to look at energy dense as a target feeding and routine enteral nutrition as underfed, because the hypothesis was all the patients who were fed with isocaloric feeds were being underfed, and this comes to around 60% of the target feeding. So the calories they got in target feeding was 1863 plus or minus 478. In this you look at it as underfeeding, 1262 plus or minus 313. When they looked at 90-day mortality, there was no difference between the underfeeding group and the target feeding. That was not statistically significant. And they looked at all 7 subgroups with organ support, infection, adverse events, hospital length of stay. there was no difference between underfeeding versus target feeding, because energy dense was target feeding and routine enteral nutrition was underfed. It constituted around 60 percentage of the caloric needs. So there was no difference. And there were two more meta-analysis. My rebuttal constitutes two more meta-analysis which came from Australian group Parikh et al. In 2016, which again showed no difference between underfeeding and target feeding. And this was another meta-analysis by Ridley et al. From Australian group, again showed that underfeeding is non-inferior to target feeding. So my argument was I have around 9 to 10 studies plus 3 meta-analyses which sort of weighs down underfeeding as being more favorable, at least non-inferior compared to the target feeding. And my argument ended with this slide. In ICU, we have always argued less is more. And over last 2 to 3 decades, we have realized in multiple domains that less is more. So we have realized that transfusion thresholds have been coming down from last 2 to 3 decades. We know that our hemoglobin thresholds have significantly come down. We now subscribe to only 7 as good enough. We don't transfuse unnecessarily. And over last 1 decade, we have realized that we should under resuscitate our patients, because we have realized over resuscitation has a bearing. So less fluids is the way to go. And in last decade, we have around 10 studies with two meta-analysis which has shown that maintaining very high oxygen in mechanically ventilated patients may have a direct correlation with their outcome. So we have subscribed to less oxygen, and we have the previous shoemaker studies have shown to us that supranormal cardiac output may not be good, and glycemic control, we have realized less glycemia is better, and we have realized maintaining lesser MAP may be better than higher MAP. And obviously in ARDS we have realized lower the tidal volume, better is the outcome, and we know the lower heart rate has a better influence on improving the outcome. So in ICU, when you look at around 8 to 9 different dimensions, we have over last 3 decades we have only realized less is better than more. So when you have all these 10 to 8 to 10 dimensions which have proven time and again less is more, I would subscribe that underfeeding is better than target feeding. So thank you very much. I would end my argument with this quote by Will Smith: a hungry stomach, an empty pocket, and a broken heart can teach the best lessons of life. So thank you very much, and please visit my website www.drpradeeprangappa.com to read, hear to these lectures and gain clarity and newer insights about this topic. Thank you.